Okay, guys, we have Dr. Paul Danick as our next speaker. And Paul's a medical oncologist and palliative care medicine consultant with Cancer Care Manitoba and the Winnipeg Regional Palliative Care Program. He's an assistant professor and theme leader for the undergraduate medicine course in palliative care at the Rady College of Medicine, University of Manitoba. Dr. Danick serves with several national organizations, including the Royal College of Physicians and Surgeons of Canada and the Canadian Partnership Against Cancer. He's currently president of the board of directors of the Canadian Consortium for the Investigation of Cannabinoids. He is also the author or co-author of several research papers, as well as textbook chapters. He serves as a reviewer for medical journals. He's been active in medical student and resident education. He has ongoing research interests in several aspects of palliative care. His interest in cannabinoids goes back to 2000 when he joined CCIC and began working with others having similar interests. He's taught many healthcare professionals throughout accredited cannabinoid education project, the annual Cannabinoids in Clinical Practice Symposium, as well as other numerous national and international conferences. Personal note, he's married, 2 children. Congratulations, they're going through university. He has a passion for watch collecting, so if anybody wants to donate a watch to him, he's happy to take it or donate. So welcome, Dr. Paul Danick.
Thank you, Prem. Okay, I think we're working here with the, yeah, excellent, good. So I wanted to give you kind of an overview of what we know about where cannabinoids and cannabis fit in the whole cancer paradigm. I also talk about palliative care because we're seeing a shift more to the use of these sorts of things within that area, especially when patients have quite advanced cancers. When we're dealing with a number of different symptoms, we can actually make things a little easier for them if we're using one compound as opposed to 10 or so. So these are a few of the learning objectives. Talk about a little bit of the prevalence of use, the indications and the evidence, and then we'll talk about the risks. I think some of that you've actually already looked at. Now, cancer is one of these issues that we see more and more of, partly because cancer is a disease of the elderly. Overall, many of our patients are older, maybe 65, 70, 75, and that's where the baby boomers are all going. They are coming into that spectrum, and we're seeing an increased incidence, and also we're seeing an increased death rate from cancers. So finding other sorts of medications to help out not only with the support of symptoms, but also the treatment of cancer is always welcome. So as I said, who exactly is using cannabis as medicine? I'm sorry, there's a little glitch there. But if you were 20 in 1967, when the Summer of Love was out there and cannabis was popular in the park and things, you would be 71 this year, or 71 this year. So you can see that people are already well advanced. For anyone who knows trivia, can you identify the rock group there? San Francisco, 1967, Golden Gate Park. Not quite, no. 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 Okay, it isn't that, but Country Joe and the Fish. Yeah, very small print. So we know who is using cannabis as medicine. In fact, I think that NAC has a lovely database that which actually gives us more information about that. These sorts of things, we know that there's about 300,000 people that are registered with the ACMPR, but of those, how many are actually using it for cancer use? And this is where we have to start digging into the evidence. So this is a paper that comes out of Washington State. So what they were doing was had a registry of cannabis users. What are they using it for? And this is really interesting because this is a patient-generated questionnaire, and you can see that they have a number of different things. Number one, appetite. They're using it for nausea. They're using it for depression. They're using it for anxiety. and also for pain. We know these are the sort of typical things that we do see in cancer patients, but interestingly, they say that they're using it for cancer. So that's an area, is it just for the symptom, or is it actually used as the treatment for cancer? So those are important things to kind of pull out when we're talking to our patients. Rates of cannabis use, we didn't know. Prior to this year, we really didn't know who's using what in terms of the cancer space, our patients. This is a paper that comes out of the Tom Baker Cancer Center. Mark Kerba is the lead senior author here. They looked at the Alberta Cancer Board database, and they were actually asking patients as they came in, were you using cannabis and what for? And you can see that there was widespread, about 45% of patients are using cannabis for one thing or another. And they said 1 in 8 respondents identified at least one cancer-related symptom. So there are people who are using it for other non-cancer-related symptoms as well. This was confirmed again. This is out of the United States. This is actually out of Lansing, Michigan. I think that's kind of close to Canada, so that's why they're kind of smelling the fumes. So the medical use in a community cancer clinic, they found that it was approximately 20% of their patients. And then they looked at early versus advanced stage. So were people using it for those symptoms of the advanced cancer? And they found that the numbers were about the same. So about 19-20% in people with early cancers versus about 17-18% in those with advanced. So of course we always wonder, why are people asking for cannabis? And especially when we're looking at cancer, where are they getting their information from? Certainly they're getting it from the internet and from friends, but they're also looking at books like this. And a number of you may have seen this book or know of David Casseret. He's a palliative care physician working in the States. He's written about this quite extensively. I've even read a recent editorial in the Journal of Cancer Oncology, in JAMA, looking at this same area. So we know the indications, especially for when we're talking about cancer. You can see the nausea and vomiting from chemotherapy. We know that there's this chronic pain associated with cancer and anorexia. Now, these are the pharmaceutical cannabinoids, but we also know that there's a lot of evidence for this elsewhere too. And if we're talking about where do we focus our symptoms that are responsive to cannabinoids, I'm really going to look at these four: the pain, anxiety, nausea, and anorexia. Talk a little bit about the evidence, and I know I'm not going to go deeply into this because you've seen this before, but interestingly, we have some preclinical evidence, especially in cancer pain models, and that's been kind of taken to our patients as well. Certainly, when we look at the distribution of CB1 receptors in the CNS, there are a number of areas where there's an overlap or an involvement of pain. The cerebral cortex, the amygdala, the hippocampus in terms of memory and learning is very important in that area. And of course, the substantia nigra, there's the addiction, reward, and movement area, which are related. If we take a look at these sort of models, this preclinical evidence, we see that there are animal models for bone cancer pain, and we also see that there is in some other areas, hyperalgesia is a common thing when we're talking about pain and cancer. Now, when we talk about the actual clinical trials, we see that they are a little less robust, if I can use those words. They do show a reduction in pain when used with the usual therapy. There are some very small studies that have been done, and more in the chronic pain area using vaporized products. We don't have any using the edibles or oils as yet. Yet we're all using it in clinical fashion. Most patients are using the oils as medicine, but we don't have that sort of literature evidence as yet. This is one of the most recent ones that looked at chronic cancer pain. This is actually using the GW products, Sativex or nabiximols, and this was in addition to their usual treatments. And you can see that although you get some benefits, and in some patients you get some significant decrease in pain, you still don't get it in the entire population. So you can see, let's go back here for a second. the rest of the world, despite these graphs looking so positive, the p-values are not significant, and yet in some areas of the states you're seeing this sort of significance. So it's a bit of a tough sell when you're saying, well, you've got some evidence, but you don't have a whole lot of it. Certainly when we start looking at real-world data, and I think that that's something that is really important to look at, and especially in cancer, because many of our clinical trials are in ideal patients, patients who are doing very well, they're young, they're able to move, they're what we call ECOG 0 or 1, but most of our patients actually are well advanced of that. So how do we actually look at what's going on in the real world? And there's a couple of papers that we've done over the years. The first one, we actually looked at our database, and it was small at that time. We picked out 25 patients, and we said, what's happening with these 25 patients? They are the ones that had gone to LPs looking for cannabis. These patients actually dropped their opioid use by as much as 70 milligrams per day of morphine equivalent. Pretty significant on a patient-by-patient basis, so we thought that was important to report on. And the other was really talking about peripheral neuropathy, something that we see quite commonly in patients who are undergoing chemotherapy, especially chemotherapy that allows them to continue to live for a long time, whether it be adjuvant or in the metastatic setting. I don't think I need to go over this very much, but just to say that the meta-analyses are showing that there's certainly benefit in our patients. And this particular one showed that we were able to favor cannabinoid, and that included some of the cancer pain studies. In terms of nausea, remember that the cannabinoid receptors are found in that nausea area. So there's a vomit center, there's a chemoreceptor trigger zone, or a CTZ, found within the brain. And you can see here that there are CB1 receptors in there. And so that would be a reasonable receptor to target. And prior to some of the better better anti-nauseants that we have, things like the ondansetrons or the granisetrons, aprepitant, we didn't have such good nausea control. So there was a lot of work done with nabilone, dronabinol, even some Sativex in some places, and we have a large literature using these in patients with nausea. Interestingly, and not many people refer to these, there were some state-by-state trials, especially when they were looking to say that smoked cannabis should be allowed for those cancer patients. And when they looked at this is a review, it's a little bit dated now, but a review of about 1,100 patients, you saw that smoking or using THC caps resulted in a significant relief of their nausea. Nausea relief means that they can continue with their chemotherapy, sometimes to the point of getting a total amount to cure. An older systematic review you can see here, and it's very interesting. I like how they phrase this, mood-enhancing adjuvants for the control of chemotherapy-related sickness. So they're really looking at the fact that if you're using the THC products, you're getting into euphoria, you're feeling better about that. But if we take a look at some other things, this is a paper that came out most recently, I think it was actually last year. So it's a systematic review of systematic reviews. You're starting to get into that whole dealing with data on data. And they said that it really isn't for first or second line, and I agree. The guidelines from our national oncology groups, both in the United States and Canada, say that we have good first-line agents, we just need to use them properly. But they do say, and they do support the use of breakthrough nausea and vomiting. They talk about this no evidence to support cannabis. And again, that just because they can't find the evidence doesn't mean that it doesn't work. And I think that that's a really important thing that we need to bring forward. That, for some people, if you're so nauseated, you can't take a pill, you can't take oil, how are you going to get your medicine in? We were talking about the use of suppositories or the use of IV drugs. The trouble with that is that you're putting your patients through a certain amount of distress to do that, whereas something like a vaporized product would be ideal for them. In terms of appetite and weight loss, we know that anorexia cachexia is a very common thing in patients with cancer, and in fact, in the more advanced cancers, you're getting more problems. We do know that the science supports this. We found that there is the switch that can be switched on and off with the cannabinoids. But when we actually look at the clinical data, it isn't quite as robust as we would like. Certainly in AIDS, HIV, there was a few studies that were quite positive. There's at least one study that was done in patients with dementia, which is quite interesting. These are patients that forget to eat. And with a little bit of dronabinol, they were able to see an increased body weight and a decrease in disturbed behavior. Now that's interesting. That to me, knowing again that we've got this population that's moving in that direction, there's a study waiting to happen. And even now, there are ongoing studies looking at these pharmaceutical cannabinoids. This one comes out of Mexico, of all places. They were looking at nabilone, and they found that there was, again, this improved nutritional status, but then, again, the side effects, reduction in pain, reduction in insomnia, an improvement in the quality of life. So even these are smaller studies looking at that pharmaceutical. Again, it gives us good support going out looking at the cannabis products as well. And as I said, taking a look at what's actually happening in the real world is very important, especially for our patients. So Israel, as we know, has a robust medical cannabis program, and they've been using it for a number of years. They're now just starting to report their findings. This is out of a single institution, and you can see out of 17,000 cancer patients, about 2% were approved for cannabis use. 40% died very quickly, but they found that there was an improvement in symptoms in the majority of patients. So what we were looking at here are those patients who rated it 4 or 5, so 5 being a great reduction in anxiety or an appetite, or improvement in appetite. And you can see, here, general well-being, 70% said that the introduction of cannabis helped out. Improved pain control, again, 70%. Efficacy of cannabis, well over 80% of patients said that it had given them some sort of benefit. A more recent paper, again coming out of Israel, looking at this, about 3,000 cancer patients over a 2-year follow-up, the different types of cancers that were involved, the breast, lung, pancreatic, colorectal. These are quite advanced, the patients who had quite advanced cancers. Breast, lung, colorectal are part of the big 4. That's the majority of people or majority of cancers that patients have. Prostate would be the other one. And you can see that they were looking at specific symptoms, including sleep, pain, weakness, nausea, lack of appetite. These are the things that the patients as well as the investigators were able to identify. Interestingly, if we take a look at pain here, 77% said that this is a real concern for them. Anything in the blue is before treatment, so you can see that the ratings are quite high, 7, 8s, 9s, and 10s, quite high up here. So 53% had 8 or better. Now, after treatment, less than 5% had 8 or better. So you can see that the kind of a brownish sort of thing had moved quite significantly down. And in pain studies, and I think that Ira can talk about this, anything more than about a move down of 2 on 10 is a real significant. So, if you're looking at these sort of numbers, this is a home run. Again, same sort of thing, this is the same trial, but the quality of life assessment, 70% said good quality of life after 6 months of treatment. We haven't been able to do that with conventional treatments in patients with advanced cancers. So here we go, a really important number to look at. This is, again, another study coming out of Israel, Dr. Barcella and his group. And when you look at this, they actually looked at patients in the palliative setting. So these are patients now where there's no further chemotherapy. These are patients that we're just focusing on symptoms. And they've listed all the symptoms there. 43% reported dose reduction in pain medication. 40%. Oh my God. You can't get that in any sort of clinical trial. So I think this is really important for us to keep in mind that we actually can see this benefit despite what other people are reporting. And then 1/3 reduce their antidepressant and anxiety meds. And certainly we know that there's a lot of patients who are on these medications during their chemotherapies or their cancer treatments. This is kind of interesting because they said there weren't too many significant adverse effects, but there was a reduction in memory in 20 to 40% of patients. Whether that's drug-induced or not, that's a little bit harder to say, but I thought that was kind of an interesting thing. And of course, you've got some limitations to the study, but again, it's a real world. It's what's actually happening to patients as opposed to very rigid conditions. The other thing I wanted to bring up for you is what's actually happening about cannabis and cancer itself, so the treatment of cancer. And these are really important things to think about, and important when you have patients coming to you talking about, well, I don't want to use this if it's going to increase my risk of cancer. Interestingly, there's been lots of epidemiologic studies that have looked at this. They find that there is not an increased risk in the numbers of lung cancers or head and neck cancers. Those were people that are usually have increased risks due to cigarette smoking. So people who are smoking marijuana seem not to have an increase in lung cancer. There's also a couple of studies that talked about a protective effect, which is interesting and needs to be elucidated out. There are a couple, though, where they're still looking at the data and trying to get a better idea. Some of it talks around non-seminomatous germ cell cancers. So these are things like testicular cancers in young men. And these may be associated with people who have high uses of recreational cannabis. Now, Dr. Price and I were talking about this just a few minutes ago. What about the preclinical evidence? Where are we seeing the benefit in terms of treatments of cancer? And people have been using cannabis products for a number of years in the research lab, both in animal models as well as cell cultures. So they would take out some cancer cells, apply cannabis to them, and they would see what sort of changes are happening. We're seeing that especially in some models such as glioma, or glioblastoma, these are CNS brain tumors that are with a dismal prognosis. People who are diagnosed, and then usually it's 6 months to a year, and they pass away. We don't have any phase 3 evidence yet, but we do have some other evidence that is starting to make it to the floor, which I think is really important to look at. This is just a review from Nature from a few years ago, looking at all the different types of cancer cells that have been investigated, things like pancreatic cancers, breast cancers, leukemias, prostates, lung cancers. So again, these are cancers that affect huge numbers of patients every year. They've developed enough information in the preclinical sphere to start to have some idea on how these mechanisms, what actually is happening when you apply cannabis or cannabis products to cancer cells. And you can see that you have what we call an induction of apoptosis, in other words, where the cells undergo a natural death process. They do not proliferate, they do not move to other areas. We actually stop the capability of the cell from moving to another spot, so you're reducing the risk of metastases. And another area here, inhibition of angiogenic signals. In other words, we're stopping the production of blood cells or blood vessels, and blood vessels are really important for cancers to continue to grow and proliferate. Another area that has been really interesting, at least to me, is looking at using the cannabis or cannabis products with chemotherapy. Some people say, well, I'll use it instead of chemotherapy, but when we add it to established chemotherapies, we see some synergism. We see some interesting benefits for patients. So here we've talked about adding THC to chemotherapy, increased brain tumor sensitivity, adding the CBD to a THC-enhanced tumor activity using temozolomide. Temozolomide is a standard treatment for most CNS or brain tumors. And then if you have that same synergism when you're using radiation, THC, and CBD, now this is an animal model, but again, you're just kind of piling it on that you can make a huge difference in these patients. Excuse me. I think this is really important for us all to remember, and again, we've brought this up, that whatever happens in animal models needs to be substantiated in human models as well. Dr. Donald Abrams is a hematologist-oncologist out of UCSF in the States and has done a lot of the seminal work in this area. So he's very supportive, but we really want to see more human trials. Anecdotal reports, this is where we start to develop hypotheses. These are both, interestingly, these are both from Canadian institutions, children whose parents said, hey, you know, I know that we're at the end of our treatment regimes, let's try cannabis and see what happens. So these patients both lived longer, much longer than anyone would have expected. And then we get into this, which I think is a really important thing. And again, we were talking about this at the table earlier. This gives us a signal that something is happening with these cells. So we have patients who have, glioblastoma multiforme. They gave them their standard sort of temozolomide, but they had patients that were taking a cannabidiol THC compound, and then there were those who did not. And although these numbers are small, the amount of benefit seems to be quite dramatic. So in terms of 1-year survival, 80% on the chemo plus the cannabis versus only 50% on those with the placebo, and that was statistically significant. Those who were on the experimental drug lived greater than 1.5 years compared to just over a year, those who were on the placebo and the chemotherapy. So really interesting signals. I know that studies like this are continuing, both this one's from Europe, but we know that there's also something that's happening out in Israel as well. So although patients are clamoring for this, what's happening with the healthcare providers? And interestingly, we see kind of a bit of a divide. Family doctors are getting up in arms. They don't particularly think that this is something that should be used. But then you have this study that came out this year. They had a questionnaire and they asked medical oncologists, what do they think about the use of medical cannabis? Look at that, 80% of oncologists discussed it with patients. So, you know, that's the overwhelming majority, and this is a questionnaire that went out to the American Society of Clinical Oncology, which most of us oncologists, both in Canada and the US, belong to. Almost half recommended it to their patients in the last year. But unfortunately, the amount of knowledge that they have is quite low. So they admit that they don't have enough knowledge, yet they say this is something that you should think about. In terms of those professionals that are working with patients with advanced disease and palliative care, we see that the same sort of thing. There's a lot of support for the legal use of this, legal prescribing. This is a United States study. I like this one. They would turn a blind eye if patients are using it, and they do not feel it is addictive. So that's, you know, I think that we've got some very enlightened medical practitioners out there, especially in the palliative care world. How are we going to be able to teach patients, how are we able to teach healthcare providers? Well, there's no programs of education in medical schools. When we, recently there was, someone looked at all of the medical schools and they said only 1 or 2 in the States even mention medical cannabis. There's yet nothing in the actual curricula of Canadian medical schools. I don't know if they are starting something in Hamilton. Yeah, a little too conservative there. I have proposed to our group that we at least include a lecture. We have a number of lectures on in palliative care. I said, why don't we have a cannabis lecture? And so that's sitting with the university right now. We'll see what happens. I'm hopeful that we can actually incorporate it in this year's programs. This is a textbook, the first one that I've seen that was available. It was actually published in the States in May of this year. We contributed an article to it. And, you know, there's also a question about how should patients be using these products. And we've all, I know that you've talked about the THC, CBD. Most patients who come to us are not wanting to get high. They really are looking at having medicine. They want to get through the chemotherapy. They want to feel better because cancer has taken away a lot of their energy. They feel crummy. They honestly feel crummy when they're going through this. In terms of prescription cannabinoids, I think that you pretty much know this. Nabilone, nabiximols are the ones that are available to us. Unfortunately, nabiximols is not covered by pharmacare. but it is by some of the private insurance companies, so third-party insurance companies. In terms of, I'm speaking to the converted here, so there's no question about that. The whole thing about where do we start goes right back to what Ira talked about before. Go low, stay low. We start at a low dose, especially with patients who have cancer. Their bodies are a little bit beaten up. They already have a number of medications that they're taking to help to control some of these symptoms. So you want to go very nice and slow. We start patients on about 2.5 milligrams. This is taken from McCallum and Russo. Caroline published this a little bit earlier. But we go about the same. I like the charts that you had made, because when I'm sitting there, I'm going, well, that's what we do. And I think it's very important to continue with that. We don't want to create terrible sort of side effects or problems for patients. We just want to increase their quality of life. Interesting, although Carolyn says euphoric effects are not required for symptom control, there's a thought that started to percolate that maybe those euphoric effects actually contribute to patients' symptom benefit. There was a paper that was just published that looked at healthy volunteers using cannabis and looking at how they responded to experimental pain. And they found that instead of abolishing the intensity of the pain, they actually saw that there was more of a, how would I call it, a subjective sensation. They didn't mind the pain as much when they were on the cannabis. So that might be one of the reasons that all these pain studies, which are measuring intensity, don't show benefit, but rather we should be looking at how do patients deal with the pain afterwards when they're on it. We talk about the use of a cannabis therapy log. I have many patients who are using that. They come back with it, and I really am able to kind of fine-tune what's going on with them afterwards. I think you probably have gone over some of the adverse effects. Certainly when I talk to my patients, I'm careful about choosing patients who are going to do well on this. I have a few patients who have unstable heart disease. I really do not recommend this for them. Not only cannabis, but nabilone as well. I've had one person that was able to access cannabis, and unfortunately, he gave himself a heart attack. He found himself in the ER with a very low blood pressure, a very high heart rate, and his heart didn't particularly like it. And it was kind of like, I wanted to tell him, I told you so, but these side effects are more the ones that we're seeing in the larger studies. So the Whitting systematic analysis looked at these sort of things, and these are the ones that we see the most. It's very interesting that some of these patients are talking about nausea, vomiting. I wonder if that's because they're using higher doses of things, or there's an uncontrolled sort of use of some of the products. Some things that are very specific to cancer patients. Remember that the chemotherapy that we're giving them, some of the immunotherapies create a process of immunocompromise. So they don't have the ability to fight off kind of standard infections. So especially patients who are undergoing quite intense chemotherapy, leukemics, lymphoma, and they can end up with this sort of thing. This is a study that, or a report that came from 2008, and it just talks about this aspergillus, which is a very nasty infection for patients, very hard to treat, and this is because he was getting his cannabis from a street source. Ira, did you talk about this, or? We talked about this. Okay, good. I don't think I need to go any further then with that. And of course, we talk to our patients all the time about this driving thing. And interestingly, I would say about half of them bring it up to us. They do not want to be driving when they're on this. How long do I have to wait? And I say, anywhere from 4 to 6 hours, depending upon the product that you're taking. And many patients have just said, well, I'm going to put my license aside while I'm on this, partly because they have cancer as well, and they might be on some other medications such as opioids and such. But I'm really happy to see so many patients are enlightened about this. So really, I think that what we're looking at here, as a lot of the other people have said, we're right on the cusp of seeing some big things. I think that there is a willingness of patients to use this. There is a willingness to bring it forward to their physicians. I know with the Cancer Care Manitoba, we've taken this on as a bit of a project, our pain and symptom group. We see the majority of patients who are coming in, so we have a kind of well-oiled machine. Patients come in, we talk to them about it, we talk to them about what sort of LPs to work with, how are we going to follow this up, how are we going to have outcome measurements and such. So it's been good because our population has been controlled that way, rather than every doctor doing a one-off or a couple of patients that way. So, and as I've heard from a number of speakers, the field continues to be interesting, and I think we're going to see that interesting going on. Okay. Sure. Sounds good. Excellent.
Thank you to Paul for that great lecture. So in the interest of time, we're going to plug ahead and continue with the next speaker. We're going to have Chirag Dave come up and speak on the evidence base for cannabis. After that, I'll be going through the referral process, the consultation process, the education process, and also going to be revealing a little bit of a sneak peek at some of the tools that we're developing to kind of put everything that you've heard about in the last couple of days into something that's usable, a quick kind of an overview, condition-based. It's something that we're continuing to work on, and you will eventually have access to that using our online system. So without further ado, we'll have Chirag come up and speak, and then I will come up after that and continue on.
Yeah, I'll put that on.
Okay. And at the conclusion, there's a big expensive table here that we paid for, so I'm obligated to use it for a panel Q&A, unfortunately.
This thing on? Oh, there it is. Okay. Sorry, just getting a drink. Okay, so when Prem asked me to speak, he said, everyone's going to do exciting things, so you got to do the boring part. So I said, okay, here we go. So the first module I'm covering here is the evidence base of cannabis. Builds off what Dr. Price, what Dr. Danick are saying, and kind of touches upon the most recent information that's out there on the evidence base for cannabis use. Like Dr. Danick said, just because what's here says limited evidence or insufficient evidence doesn't mean it's good, not good or good for that condition. My personal biases are sometimes different than what's here, but I am presenting objective information, so that's how we'll take this one. So some learning objectives: look at the evidence base surrounding cannabis use, objectively assess and draw meaningful conclusions from the available evidence, identify any gaps in the information and therefore where research is going to go, and identify any resources available to patients and healthcare practitioners. And throughout, when I refer to healthcare practitioners, I'm including the educators that work at NAC and other places. A lot of them are well informed and even know more than any of us would know about these topics. So taking you back to school, a couple years back for some of you, these are the types of evidence in rank of how strong they are. Meta-analyses are a statistical review of all data across many studies. Systematic reviews are the collection of all empirical data of randomized control trials. Guidelines are similar, but they typically drive a narrative to them. RCTs, we know all about these. These are placebo-controlled, typically. Cohort studies, looking at those who had a drug versus those who haven't over a period of time. and case-controlled studies and case series reports. Typically, these are anecdotal reports, so lowest on the rank. I just brought this back to remind you a bit about the endocannabinoid system, so you can get it in your head as we go down the evidence. Two major receptors located in different places, and THC and CBD THC is a partial agonist with low to moderate affinity at both. CBD has negligible affinity at both, but works on the other receptors, the TRPV1, GPCR, and the nuclear receptors. So some stats that I just pulled off Stats Canada between January and April of 2018. We can see kind of a bimodal, a little smaller on the other end, but higher percentage of people have used cannabis in the less than 34 years old. Surprisingly, a lot of people between 15 and 24. Kind of peters off, but there is a higher spike in the 55 to 64, and that supports what we've all been saying, that the baby boomers are now using cannabis for the chronic illnesses and acute illnesses that they're experiencing. Of all these above users, about half say they use cannabis daily or weekly, and 80% of Canadians said they would not be more likely to try or increase their cannabis consumption once cannabis is legalized as of October of this year. And when I say legalized, I mean recreational cannabis. Cannabis currently today is legal. Here are some common medical uses of cannabis. There are many more. The list is huge, but I've highlighted a few. We have pain, acute, chronic, and cancer. Cancer itself, palliative care, nausea and vomiting, MS, epilepsy, OA, anxiety and depression, PTSD, and sleep disorders. And with this, we'll look into evidence for each of these. Okay, so this is where it gets dense. So I'm warning you. The Cochrane Review came out in 2018 and had a collection of a lot of good information. It looked at 16 studies with about 2,000 participants. The studies were mixed across the board in terms of what drug they used. Well, we haven't seen a lot of studies just focused on the herbal cannabis or the cannabis oils. So a lot of the data that we have today, we're inferring off of Sativex, Nabilone, et cetera, and Dronabinol. Overall, the results, they called it low-quality evidence, but it said that cannabis-based medicines may increase the number of people achieving 50% or greater pain relief versus placebo, which is amazing. It's a big number. Next was moderate quality evidence, saying that more participants withdrew from the studies due to non-serious ADRs versus placebo. And later on, we'll look at what those non-serious ADRs are. But Dr. Danick and Dr. Price covered it. It's the headache, the euphoria, that kind of thing. So the overall conclusion from this is the potential benefits of cannabis-based medicines may outweigh the potential harms for chronic neuropathic pain. Going further into chronic pain itself, the Whitting et al. Study, which is a great one to look at for your reference, had 28 RCTs and about 2,500 patients, found that plant-derived cannabinoids were 40% more likely to reduce the pain than the control. For cancer itself, this is treatment of the cancer disease, looked at one systematic review of 35 studies looking at anti-tumor effects of cannabinoids in gliomas. And the results show that they're in vivo evidence with respect to anti-tumor effects. So we have some information, but there's insufficient evidence to support or refute the effectiveness for cancers, particularly gliomas. So CINV, before I go into this, it's been mentioned, I myself had chemotherapy and had a ton of nausea and vomiting. I took the standard treatment on Dancitron, Simatil, and found that day one after the chemotherapy, I'd have maybe a dozen episodes of nausea and vomiting. And I tried it for a few sessions of chemotherapy because I wanted to be objective as a healthcare provider and say, okay, I'm going to do what they tell me. So I tried it out. I never went to the NK1 antagonist, but after 2 sessions of chemotherapy, I said, okay, I'm going to try cannabis, and it reduced the episodes of nausea vomiting to about 3 a day, which is pretty significant in my anecdotal case. So looking at the evidence that's out there, The Whitting et al. Study compared placebo to active drugs, which included prochlorperazine as one of them, and concluded that there's a greater benefit of cannabinoids versus active agent or the placebo, but it wasn't statistically significant, which is important to know. The next Cochrane review showed that 3 of these trials had a higher chance of complete absence of vomiting with cannabinoids, and another 3 had a complete absence of nausea and vomiting. When compared to the standard of treatment, there was no significant difference in control of nausea, vomiting, or both. 7 of the trials showed that patients preferred the cannabinoid therapy versus the comparator, even though there was a higher incidence of adverse events with the cannabinoids. And the reason was because it was a quality of life thing. It was, as Dr. Price calls it, a functional outcome. That's what they preferred. MS, this one's very well researched, and Sativex, this is what it's used for. It looked at a pool analysis of 3 of 11 trials showing that cannabinoids decreased patients' self-reported spasticity by a score of 0.76 on a 0 to 10 scale. And on the Ashworth scale, improvement with oral cannabinoids, but wasn't statistically significant. So we can say that oral cannabinoids are an effective treatment for improving patient self-reported spasticity symptoms, but the same can't be said for clinically measured spasticity. Okay, on to epilepsy. So I think Dr. Price said this yesterday, there's a lot of adults trying to use cannabis for epilepsy with maybe not so much success. Yeah. Epidiolex, however, which is a cannabidiol oral solution, has been approved by the FDA for Lennox-Gastaut syndrome and Dravet syndrome, 2 pediatric epilepsies. For Lennox-Gastaut, 2 studies with patients taking at least 2 other anti-epileptic drugs, the AEDs, experienced a reduction in the frequency of drop seizures versus placebo within the first 4 weeks of treatment, and generally thereafter. In Dravet, they had a single study with patients on at least 2 other AEDs, and these patients had also a significant reduction in the frequency of seizures. Now, you'd say like this isn't enough data to make such a conclusion or to make an approval, but the results were so significant that they had to approve the drug. So I've taken a snippet from the study and from Epidiolex's package insert, just looking at the 2 studies. And we can see that at the 10 mg per kg per day, there was a not applicable effect for study 1, but in study 2, at 20 mg per kg per day, there was a significant improvement. And at study 2, we can see a significant improvement at both dosages. This is the 3rd study, similar results showing improvement. Okay, sleep disorders, which is another infamous use of cannabis. 2 RCTs were looked at here, showing some improvement in sleep with the use of dronabinol versus placebo, and nabilone versus amitriptyline, another popular treatment for sleep disorders. And a meta-analysis of 11 trials showed a greater improvement in sleep quality and preventing disturbances with cannabinoids. So you can overall say that there's moderate evidence that cannabinoids, particularly Sativex, are an effective treatment to improve short-term sleep outcomes in sleep apnea, fibro, chronic pain, and MS. PTSD, this is another one. I'm very interested to see how it works. A lot of anecdotal success with PTSD, and there was a lot of push for using cannabis for PTSD in the veteran population here in Canada over the previous years. A single controlled clinical trial is currently underway in Canada for this purpose, and one notable one was a single crossover trial of nabilone in 10 Canadian military personnel showing overall improvement in nightmares, global clinical state, and general well-being. Anxiety, another widely used indication with limited evidence available. One good trial of N equals 24 patients taking 600 milligrams of CBD versus placebo looked at an anxiety factor on a 100-point scale and showed improvement versus placebo. Now going on to the limited evidence section. So remember that chronic pain was once in the limited evidence category. So similar, these things can move in and out of these categories. There's limited evidence for cannabis use in increasing appetite and weight loss in HIV and AIDS, the improvement of symptoms in Tourette's, the improvement of symptoms and quality of life in Crohn's disease. There's limited evidence to say that cannabis is ineffective for dementia or ineffective for glaucoma, IOP, intraocular pressure. Limited evidence to say that there are better outcomes after TBI or intracranial hemorrhage, which I'm very interested in seeing because I've seen a lot of anecdotal evidence in this situation, and that is ineffective for the reduction of depressive symptoms in chronic pain or MS, et cetera. I said it once there for you, Ira. Moving on to insufficient disease or insufficient evidence to support or refute, we have cachexia syndrome and anorexia nervosa, ALS, Huntington's, Parkinson's, spasticity associated with paralysis due to spinal cord injury, UC, ulcerative colitis, dystonia, addictions treatment, which, again, I've seen a lot of anecdotal benefit, but not any clinical evidence, schizophrenia and other psychoses, and OA. So where do patients go for information? We have access to a lot of sources, and we know where to look. But through my experience in the field, I've seen that patients go to websites like Leafly, Lyft, which is another Canadian website, Strainprint. They talk to each other on forums. They use word of mouth to determine if it's right for them. They're healthcare providers, which we are lucky enough to start educating in seminars like this. Licensed producers. As some of you know, licensed producers have their own patient hotlines that are sometimes staffed by healthcare providers, sometimes not. And patient service providers or patient education services. Push on. So to wrap it all up, we can say that cannabinoid products may have benefits in chronic pain, epilepsy, chemotherapy-induced nausea and vomiting, and spasticity in MS. We need additional research to explore it in other disease states. And just know that patients often go to anecdotal resources without going to you first. I mean, we've seen it with Dr. Google all the time, right? So I think it's excellent that NAC has such a program where they'll educate your patients, because that takes a lot of the work out of trying to research all this on your own. And that's it. My references. If you couldn't keep up with them, I think you can ask for a copy of the reference slide at the end.
Yeah, we're going to be putting this
on their platform. Yeah, so all of this you'll be able to access. And use this as ammunition to make your clinical decisions, whether to support or refute an authorization for cannabis. It's a good source. Again, I told you, it doesn't necessarily agree with what I say personally, but this is the objective evidence that's out there. Any questions about that? Coffee break? Okay, everyone, how long? I'm already hooked in.
He'll be back. He's not going anywhere. So we're just kind of rejigging the schedule so that I know it's a Sunday and we don't want everyone kind of hanging out. I'm sure you'd rather be somewhere else than here at 6 p.m. So we're going to try to move the schedule along. What we're going to do is Ira's going to lead some yoga. No? Okay, no, maybe not. So he does it in some of his other talks. So what we're going to do is just have a quick coffee break. We'll be back here with the community pharmacist involvement in the program. I'm also going to talk about the MCMS program itself and reveal some of the tools that we've been working on, which will help consolidate some of the things that you've learned here, specifically with regards to anxiety, nausea and vomiting, MS, muscle spasticity, et cetera. So it'll be tools that we could work on, or that will be useful for you in the future. So we'll take about 10 minutes, and then we will come back. We're also going to have a panel Q&A as well. We'll have a panel Q&A first to start things off.